of fingolimod versus interferon Beta-1a pediatric multiple sclerosis. Definition: multiple sclerosis is the result of an inflammatory and demyelinating processes of the axonal sheaths of the central nervous system. It manifests with focal, motor sensory, cognitive alterations.
Multiple sclerosis is a demyelinating disease of the central nervous system, which includes the brain and the spinal cord. Myelin is the protective sheath that surrounds the axon of neurons, allowing them to quickly send electrical impulses. This myelin is produced by oligodendrocytes, which are a group of cells that support neurons. In multiple sclerosis, demyelination happens when the immune system inappropriately attacks and destroys the myelin, which makes communications between neurons break down, ultimately leading to all sorts of sensory, motor, and cognitive problems. Now, the brain, including the neurons in the brain, is protected from things in the blood by the blood-brain barrier, which only lets certain molecules and cells through from the blood. For immune cells like T and B cells, that means they have to have the right ligand or surface molecule to get through the blood-brain barrier. This is kind of like having a VIP pass to get into an exclusive club. Once a T cell makes its way in, it can get activated by something it encounters. In the case of multiple sclerosis, it's activated by myelin. Once the T cell gets activated, it changes the blood-brain barrier cells to express more receptors, and this allows immune cells to more easily bind and get in. It's kind of like bribing the bouncer to let in a lot of people. Now, multiple sclerosis is a type 4 hypersensitivity reaction, or a cell-mediated hypersensitivity. And this means that those myelin-specific T cells release cytokines like interleukin-1, interleukin-6, tumor necrosis factor alpha, and interferon gamma, which together dilate the blood vessels, which allows more immune cells to get in, as well as directly cause damage to the oligodendrocytes. These cytokines also attract B cells and macrophages as part of the inflammatory reaction. Those B cells start to make antibodies that mark the myelin sheath proteins, and then the macrophages use those antibody markers to engulf and destroy the oligodendrocytes. Without oligodendrocytes, there's no myelin to cover the neurons, and this leaves behind areas of scar tissue, also called plaques or sclera. In multiple sclerosis, these immune attacks typically happen in bouts. In other words, an autoimmune attack on the oligodendrocytes might happen, and then regulatory T cells will come in to inhibit or calm down the other immune cells, leading to a reduction in the inflammation. Early on in multiple sclerosis, the oligodendrocytes will heal and extend out new myelin to cover the neurons, which is a process called remyelination. Unfortunately, though, over time, as the oligodendrocytes die off, the remyelination stops, and the damage becomes irreversible with the loss of axons. Just like other autoimmune diseases, the exact cause of multiple sclerosis is unknown, but it's linked to both genetic and environmental factors. Genetic risk factors include being female and having genes that encode a specific type of immune molecule called HLA-DR2, which is used to identify and bind to foreign molecules. Environmental risk factors might include infections as well as vitamin D deficiency, which is an interesting one because it might help explain why the rates of multiple sclerosis are higher at the northern and southern poles compared to the equator, where there's a lot more sunlight. Together, these genetic and environmental influences might lead to the body not killing off immune cells that target myelin. So, it turns out that there are actually 4 main types of multiple sclerosis, based on the pattern of symptoms over time. To break this down, we can use a graph with time on the x-axis, where time refers to the lifespan of the individual, and disability on the y-axis. The first and by far the most common pattern of multiple sclerosis is called relapsing remitting multiple sclerosis, or RRMS. This condition is what we just described, bouts of autoimmune attacks happening months or even years apart, and causing an increase in the level of disability. For example, during a bout a person might lose some vision, but then it might be followed by improvement if there's remyelination. Unfortunately though, more often than not, the remyelination process isn't complete, so there's often some residual disability that remains. And that means that with each attack, more and more the central nervous system gets irreversibly damaged. In the relapsing remitting multiple sclerosis type, there's typically no increase in disability between bouts, so the line stays flat during that time. Now the second type is called secondary progressive multiple sclerosis, or SPMS, which initially is pretty similar to the relapsing remitting type, but over time the immune attack becomes constant, which causes a steady progression of disability. The third type is primary progressive multiple sclerosis, or PPMS, which is basically one constant attack on myelin, which causes a steady progression of disability over a person's lifetime. The final type is progressive relapsing multiple sclerosis, or PRMS, which is also one constant attack, but this time there are bouts superimposed, which means the disability happens even faster. Specific symptoms vary a lot from person to person, and largely depend on the location of the plaques, and multiple sclerosis typically affects individuals between the ages of 20 and 40. Symptoms related to bouts can typically worsen over weeks and can linger for months without treatment. One common trio of multiple sclerosis symptoms is called Charcot's neurologic triad, and it includes dysarthria, which is difficulty or unclear speech, nystagmus, which is involuntary rapid eye movements, and an intention tremor. Dysarthria is due to plaques in the brainstem that affects nerve fibers that control muscles of the mouth and throat. And this can interfere with conscious movements like eating and talking, and could lead to things like a new stutter, as well as unconscious movements like swallowing. Nystagmus is due to plaques around the nerves controlling eye movements. Plaques around the optic nerve causes loss of vision in one or both of the eyes because of damage to the optic nerve, optic neuritis. Sometimes there's blurring or graying of the vision, or alternatively there might be a dark point in the center of vision. Additionally, if there's damage to the nerves controlling eye movement, then eye movements can be painful and there can even be double vision, if the eyes no longer move in a coordinated way. Finally, intention tremors can be caused by plaques along the motor pathways in the spinal cord, which can affect outbound signals like skeletal muscle control. Motor symptoms can include muscle weakness, muscle spasms, tremors, and ataxia, which is a loss of balance and coordination. In serious cases, this can lead to paralysis. In addition, plaques in the sensory pathways can affect inbound signals, like sensations from the skin, which causes symptoms like numbness, pins and needles, and paresthesias, which are often a tingling feeling, but might also be a painful itching or burning sensation. Occasionally, there can be very specific sensory symptoms, like Lhermitte sign, which is when an electric shock runs down the back and radiates through the limbs when a person bends their neck forward. Plaques can also involve the autonomic nervous system, which can lead to bowel and bladder symptoms like constipation and urinary incontinence, as well as sexual symptoms like sexual dysfunction. Finally, multiple sclerosis activity to the brain, causing poor concentration and critical thinking, as well as depression and anxiety. Multiple sclerosis is typically suspected when there are multiple neurologic symptoms separated in space, which is attributable to damage in different locations in the nervous system, as well as time, meaning separate bouts or flare-ups, as well as remission. The diagnosis of multiple sclerosis is supported by an MRI that shows multiple central nervous system lesions, called white matter plaques, since these regions tend to have a lot of myelin. So in the cerebrospinal fluid, there might be high levels of antibodies, which indicates an autoimmune process. Finally, a visual evoked potential can be helpful as well, which measures the nervous system's response to visual stimuli. For treatment, there's no cure for multiple sclerosis, but there are medications which are particularly effective for the relapsing remitting type because they lessen the severity of relapses and make them happen less frequently. Medications like corticosteroids, cyclophosphamide, which is a cell cycle inhibitor, and intravenous immunoglobulin can all be used to help blunt the autoimmune process. In addition, plasmapheresis can be effective as well, which is when the plasma is filtered to remove disease-causing autoantibodies. Chronic treatment for multiple sclerosis includes immunosuppressants like recombinant beta interferon, which decreases the level of inflammatory cytokines in the brain, as well as increases the function of T regulatory cells. Other immunosuppressants actually block T cells from getting into the brain by interfering with the cell surface molecules they use to gain passage through the blood-brain barrier. Unfortunately, though, there are fewer treatment options available for progressive multiple sclerosis. Instead, treatments are often targeted at managing specific symptoms, everything ranging from depression to bladder dysfunction. Physical therapy and cognitive rehabilitation therapy can be particularly helpful with sensory, motor, and cognitive symptoms. Finally, there's also an increasing interest in the role of vitamin D as an effective treatment. Alright, as a quick recap, multiple sclerosis is a chronic and progressive autoimmune disorder, and the most common pattern is the relapsing remitting type, where individuals have flares that come and go, with each one slightly worsening their overall condition. During a flare, T cells cause inflammation and damage to oligodendrocytes in the central nervous system, which leaves behind scarred areas of demyelinated neurons called plaques, which causes a variety of symptoms depending on the location. Thanks for watching. You can help support us by donating on Patreon, subscribing to our channel, or telling your friends about us on social media.
Applications in nursing. Control of viral signs. Perform a control of adherence to the treatment. Prevent complications secondary to the disease.
The diagnosis of pediatric MS can be challenging, particularly since most pediatricians will only rarely encounter a kid with this. The frequency is maybe 1 per 100,000 more or less, so it's not a common thing. And the other challenge is that sometimes little kids have symptoms they don't tell anybody about it. So as an example, a typical presentation is optic neuritis, which is inflammation of the optic nerve, and the symptoms are loss or diminishment of vision. And we've run into situations where a child will have that occur but not say anything until it happens to the other eye. Then they can't see at all, and then you go back. So vision changes, such as loss of vision, very common presentation. Another symptom that can happen is problems with weakness and balance. And just the other day, I saw a youngster who saw their pediatrician with such complaints that they were dragging their leg, and it was thought, oh, they must have just slept on their leg funny that night or something. So it can be minimized because so often kids get better with just on their own with so many things. Another common symptom can be sensory changes like numbness or tingling. That's a little bit more common among the older kids. So the youngest child that I've ever seen with MS had their first symptoms at 20 months, and the second event was extremely rare. Much more frequent are teenagers, and so MS occurs among those who are 13 and up, and over the age of 17, it's no longer considered pediatric. But the teenagers as a group are the bulk of the kids who have pediatric MS. Those under, say, 12 are a smaller percentage. The thing about MS that's really important to recognize is that this is a relapsing remitting condition. So whereas adults can sometimes begin with a progressive course, that's so rare in pediatrics that if you're dealing with a progressive cognitive problem or a progressive walking problem, you're not dealing with MS, because MS occurs with lasting several days, maybe even some weeks, but then there's improvement till the next attack occurs. The reason I bring this up is that so often symptoms of cognitive challenges occur in kids with learning disabilities, dyslexia, troubles. And for that to be the only problem, presenting problem and a progressive problem would be unlikely. MS. On the other hand, with MS and a diagnosis of MS, there can be cognitive changes. The good news is that most of these are relatively mild, but they can interfere. So cognitive slowing is one of the things that can happen. Challenges with multitasking. And sometimes kids will benefit from some accommodations like extra time for tests. In general, one of the bigger challenges with kids, particularly with teenagers, is they want to feel like everybody else. And so having to have a chronic illness, miss appointments, make appointments, miss school, and sometimes miss exams and classes, that can all cause a lot of emotional distress. And when you've got some cognitive slowing and you add on to that emotional distress, it can create even a bigger problem. So it's important that MS be diagnosed promptly, that treatments be provided efficiently, and that psychosocial support be available so that it's not so challenging for these young kids.
Pros and cons. Pros. The progression multiple sclerosis is slower in children than in adults, and both the time to accrue physical disability and the time to reach a secondary progressive. Cons. Eye problems, issues with blood pressure and heart rate. Issues applied in Ecuador. Multiple sclerosis typically appears in young adults, but approximately 3% to 5% of cases have an onset that occurs in childhood or adolescence, usually with a relapsing remitting pattern.
Pediatric onset multiple sclerosis accounts for 3 to 5% of cases of multiple sclerosis and is mostly characterized by a relapsing remitting pattern. Fingolimod is an oral sphingosine 1-phosphate receptor modulator used for relapsing forms of multiple sclerosis in adults. Trials in adults showed that fingolimod once daily significantly reduced progression of disability in relapsing remitting multiple sclerosis as compared with placebo. This randomized double-blind trial compared fingolimod with intramuscular interferon beta, the current standard of care in pediatric patients with multiple sclerosis. 215 patients between the ages of 10 and 17 were randomly assigned to oral fingolimod once daily or to intramuscular interferon beta once weekly for up to 24 months. At up to 24 months, the average number of relapses per year and the average rate of new or newly enlarged T2-weighted MRI lesions per year demonstrated statistically significant differences between the fingolimod group and the interferon beta group, favoring fingolimod. 18 patients in the fingolimod group and 7 in the interferon beta group had at least one serious adverse event, with 6 patients in the fingolimod group and 1 in the interferon beta group had convulsions. This trial demonstrated the superior efficacy of fingolimod over interferon beta in reducing relapses in pediatric multiple sclerosis. However, more patients had serious adverse events with fingolimod. Full trial results are available at nejm.org.
Conclusion. Fingolimod was associated use a lower rate of relapse and less accumulation of lesions on MRI over a 2-year period than interferon Beta-1a.
Diagnosis of multiple sclerosis requires that there is dissemination of a disease both in space, which means involving multiple areas of the central nervous system, so the optic nerve, the brain, or the spine, and that it is disseminated in time, meaning there is more than one event. And that can be confirmed clinically by another attack or by MRI, where there are new changes that indicate new disease. The McDonald criteria are international criteria that were created by multiple sclerosis to help clinicians make the diagnosis of multiple sclerosis in a person presenting with the first attack of what might be multiple sclerosis. And so the most recent version, the 2017 McDonald criteria, allow you to confirm the diagnosis of multiple sclerosis in a person with a first attack, so they have not yet had the multiple part, at least not clinically, if their MRI shows multiple, what we call lesions, or multiple areas of where the immune system has attacked in the brain and or spinal cord. It also includes spinal fluid oligoclonal bands, which is a test that indicates the immune system being active within the spinal fluid bathing the brain and spine. And the criteria have a specific set of features that help identify an individual with multiple sclerosis. And the rationale for that was so that we could promptly initiate therapy even after a first event for someone that we are confident has multiple sclerosis. Multiple sclerosis is a diagnosis that has clinical criteria for relapses and remissions over time, and MRI features that are characteristic. There is no single blood test that confirms a diagnosis of multiple sclerosis. And even the spinal fluid test, the oligoclonal bands that I mentioned, while very, very common in individuals with multiple sclerosis, are not specific to multiple sclerosis. There are certain infections that can also have oligoclonal bands, for example. So the diagnosis of multiple sclerosis requires that we exclude other diagnoses. As a clinician or neurologist, my job is to carefully take a history, carefully examine my patient, and carefully review all of the blood testing, spinal fluid results, and MRI features in order to apply the McDonald criteria to confirm the diagnosis. I have to rule out other diagnoses, and these can be quite broad. So, for example, if a patient presents with an attack in the spine or the optic nerve, I would typically evaluate whether or not they have these antibodies or a blood test for MOG, as I mentioned previously, or for another somewhat similar disease where a person might have antibodies to aquaporin 4. These two tests would point me away from a diagnosis of multiple sclerosis and toward a different form of relapsing disease that also has some overlap clinically with multiple sclerosis, but a different outcome and often slightly different therapy. We also always have to rule out other different diagnoses, such as sometimes migraine, infection, always. We need to exclude genetic disorders, some of which can mimic multiple sclerosis. And in older adults, of course, we rule out things like stroke or vascular abnormalities. Sometimes that's pretty easy to do, and sometimes it's not. And we have to be very careful and evaluate a patient very thoroughly and with expertise to be sure that we give the correct diagnosis.
The way to diagnose pediatric MS is first, always, to take a good history and to look for neurologic symptoms and signs that occur, persist, and then sometimes on their own begin to get better. By definition, an episode of neurologic dysfunction from MS should last at least 24 hours. The next step for the pediatrician is to get help from a pediatric neurologist if there's one available. And therefore, doing a thorough neurologic exam is important. Fortunately, often children with MS will have very intact neurologic exams unless they're in the midst of a clinical relapse. But subtle things like loss of vibration in their toes, slowing of fingers, things like that are things to look for. Loss of vision, of course. And then what's made a huge difference in the diagnosis of MS is neuroimaging with MRIs. So MRI is probably the most sensitive test that we have, and there have been steps made to help distinguish the signs of MS on MRI from abnormalities on MRI that could be due to other things. The other thing that sometimes is necessary, depending on the age of the patient, depending on the clinical presentation, there may be a need for a spinal fluid analysis, which would be a lumbar puncture. And because vision is so frequently affected, it can be very helpful to get an assessment by an ophthalmologist, either a pediatric ophthalmologist or a neuro-ophthalmologist who's comfortable seeing children, because you can identify changes in the optic nerve and the layers of the nerve
to the central nervous system. Children have very active disease, both clinically, they tend to have more relapses early in the disease than adults, but also by MRI. So, for example, one of my patients had 179 brain lesions when he presented, just highlighting that there is a phase of this disease that happens before the first attack that can be quite dramatic. So the MRI is a picture, a snapshot of how active the immune system has been in the brain. We can also take pictures of the optic nerves, the nerves that supply the eye, and the spinal cord. Using MRI, we also can quantify exactly how much activity has happened. So we can not only count the number of areas of what we call lesions, but we can actually measure the volume of the brain that is occupied by lesions, so-called lesion volume, which gives us a quantifiable measurement of the amount of disease activity that we can use, at least when you have high-quality images, to evaluate how a person does over time, or in the context of a clinical trial, whether a treatment is reducing that disease burden and preventing new disease. We also can measure the impact of the disease on brain health, and by that I mean the volume of the brain and the structural integrity of how the brain connections are forming. And in pediatric multiple sclerosis, it's been found that the multiple sclerosis onset in early childhood or teenage years negatively affects normal brain growth. And of course, we hope that new therapies will prevent that problem and allow children to undergo normal brain growth and maturation. But we can measure these important findings by highly specific MRI sequences.